screen. Today our guest is Professor John DelGaudio, which is a professor and vice chair and chief of Rhinology and Sinus Surgery of the Department of Emory University, and which was also the past president of the American Rhinologic Society. Good morning, John.
Good morning. Well, good afternoon right now.
Yes, it depends on where you are connected from. We have many people connected right now from all around the world, and I'm very excited to have John in this particular topic, which I assigned him due to his amazing experience after many years. And CSF leaks are, as you know, one of the challenges that we're figuring out every day in our activities. So today, John is going to talk about the CSF leaks and how to manage and reconstruct those defects and how to recognize those defects. There's no other introduction. Please be aware that all the questions should be asked at the end of his talk, and I will let the torch to him to talk about his topic. Please go ahead, John.
Well, thank you very much. It's my pleasure to participate in this educational activity. When you came to me with the idea, I thought it was a fantastic idea. I wish we had more like this in the United States. We do have some, but this is just a very good educational activity. So I'm going to talk about skull-based defects. We'll do a little background. So causes of CSF leaks are listed here. Iatrogenic leak from either neurosurgery or endoscopic sinus or skull-based surgery are the most common causes. Trauma, and then spontaneous defects, most commonly from benign intracranial hypertension. This is something we see a lot here in the United States, especially where I am in Atlanta, Georgia, because we have a very heavy population, and that's the main risk factor. The symptoms, obviously the most common symptom, as you see in the video, is clear rhinorrhea. It's usually unilateral, rarely can be bilateral. It can be constant or intermittent. It usually increases with exertion, cough, or the head down position. It can be associated with headaches. It's frequently not. If a patient has headaches that improve with lying down, especially with these other symptoms, then you need to think about low pressure headache, which can be from a CSF leak. Ear fullness is another thing we need to pay attention to. This video, you think this is a significant CSF leak from the nose. This is actually an otologic leak that's draining through the eustachian tube. So we always need to consider the middle ear as a causative area in CSF leaks, even with rhinorrhea. The workup of these patients, nasal endoscopy is very important, but a negative nasal endoscopy does not rule out a leak. Someone who's actively leaking, the most beneficial thing is to collect the fluid for beta-2 transferrin, which is what we primarily test in the United States. I know you can test tau transferrin also, or beta-trace protein rather. We don't have that capability except in research, so we do beta-2 transferrin, and it's highly specific, but it can have a false positive. So you need to be able to correlate that with the radiologic studies, which high-resolution CT is really the mainstay of workup of these patients. You see a couple of images here. There's a skull-based defect with ethmoid opacification. If we're concerned about meningoencephalocele, we'll move on to an MRI, which shows that we actually have brain tissue extending into the ethmoids in this patient. On endoscopy, it would be nice if we can frequently see what's on this left video, which is clear rhinorrhea. That is indicative of a CSF leak. If we see a unilateral nasal mass, do not biopsy this, especially if you look at it, it's pulsatile. This is a large meningoencephalocele. We then want to do a radiologic workup to confirm a skull-based defect. Iatrogenic skull-based injury, it should be low in endoscopic sinus surgery. Its incidence should be well below 0.5%. But if you do enough sinus surgery, it will eventually happen to you. So be prepared. We need to recognize it when it happens and then to treat it. If it happens intraoperatively, the best treatment is either repairing it at the time or stabilizing it and getting it to someone who can repair it. When we're doing sinus surgery, we need to remember the angle that we're approaching the ethmoids. The horizontal basal lamella of the middle turbinate is really our landmark. We want to stay right above that. And if we do, This green arrow shows that we will come to the posterior ethmoids right in front of the face of the sphenoid. If we're too high an angle, we can enter the ethmoid roof much more anterior than we're expecting and result in a CSF leak. If we're suspicious for a CSF leak, what you want to look for is what's called a washout sign. This is an area or a sign where you have bloody tissue from sinus surgery, but you have central clearing. And that's a sign of a possible CSF leak. If there's any bone violation or any pulsatile tissue, we need to be concerned. Excessive bleeding at the posterior skull base also can be indicative of a posterior ethmoid artery injury. If we have a posterior ethmoid artery injury, that is almost always in the skull base, so it's usually associated with a skull base breach. We published a paper back in 2008 where we had patients who had undergone sinus surgery and had a CSF leak or a skull base defect. The findings were very interesting. What we found is the majority of these patients, over 80%, had little or no disease at the site of the leak. Here's some examples. Here's a patient who has essentially clear sinuses except for the left maxillary. You see, here's the post-operative CT that shows that there's a defect in the lateral lamella of the middle turbinate where there was no disease. Another example, there's some ethmoid disease here, but a clear ethmoid superiorly. The site of the leak was right above that clear cell. And the reason for this is that if you've done surgery on minimal disease or areas with no disease, you know that the mucosa strips very easily and the bone is very thin. There's no osteitis, so it's much more easily injured. There's another example. This is a patient who someone performed a total middle turbinate resection and resected it right at the attachment. As you can see, this pulsatile area here, which is a skull base defect. So if we're doing middle turbinate resections for any reason, we need to leave a stump of attachment at the skull base. Idiopathic intracranial hypertension is something we commonly see in Atlanta. I probably operate on one of these a month for a spontaneous CSF leak. It's most common in women, 4 to 8 times more common than in men, and the age range is anywhere from 20 to 50, but it can be found in older or even younger age ranges. It is related to obesity. The greater the BMI, the greater the risk. And these patients not uncommonly will have multiple skull base defects. So we need to look for multiple areas. The most common areas involved are the cribriform plate, as we can see in this top picture, and then the lateral recess of the sphenoid sinus. They're the most common areas. And again, multiple areas of thinning and bone defect are common. Always assess the middle ear in these patients. So now that we know causes and what to look for, how to work up these patients, sorry about that, let's talk about repair of skull base defects. And no matter where we're repairing the defect, there are common principles, and these really need to be paid attention to. First, we need to get adequate exposure. If we can't get to the leak, we can't fix it. We need to then identify the site of the leak and circumferentially expose the bone defect. We need to take all the mucosa from over and around the bone defect. If the bone edges are cratered, meaning that they're not flat, and this happens with long-standing defects, especially meningoceles and meningoencephaloceles, we need to flatten those edges to provide a good bed for grafting. We then want to resect or reduce the meningoencephalocele and then repair the defect. And we'll talk a lot about repairing the defect. When we repair these defects, we cannot be afraid to make the defects larger because we need to have the ideal situation for repair. Sometimes taking off part of the bone, removing excess mucosa is important in order to get a good repair. When we identify the defect, again, this slide is a little out of order, but again, the high resolution CT scan is the #1 imaging modality to identify the defect. MRI is for encephaloceles or meningoencephaloceles. I use image guidance intraoperatively, although frequently it's not necessary, but it does, especially in difficult cases, negate the need for fluorescein or lumbar drain. I do not use fluorescein. I do not use lumbar drains, even in idiopathic intracranial hypertension. And I'll show you why. in some cases. As far as graft materials, just about anything is going to work, especially for low flow leaks. So we can use mucosa that we harvest from the middle turbinate or septum or nasal floor. I prefer the septum or the nasal floor. Collagen matrix or dural replacement grafts are very easy to use. They do not have a donor defect. We can shape them, we can layer them, and you'll see in my videos I use a lot of these grafts. Acellular dermis or alloderm I don't use anymore, but it is an option. And then pedicle grafts, especially nasal septal grafts for larger defects or high flow defects are very good in reconstruction. Other considerations, bone grafts. I rarely use bone grafts. I used to use them more frequently. I will occasionally use them now for large, not large defects, but meningoencephaloceles. Otherwise, the soft tissue grafts tend to scar inadequately and thicken over time. Lumbar drains, again, reserved for failures or very high pressure defects, but there are significant risks. And again, I rarely use fluorescein, even so this is one of the few cases that I did use fluorescein. It was not necessary in this case because we see an obvious defect in the lateral recess of the sphenoid sinus with a meningoencephalocele. But this is one of the reasons why I do not use lumbar drains. This is a patient who had a skull-based tumor that I resected from the frontoethmoid area. Post-operative day 1, he complained a little bit of moisture in his nose, and without consulting me, our neurosurgery colleagues put in a lumbar drain. That immediately resulted in sucking air through the drain and causing a tension pneumocephalus. This is a situation where I normally would not have done anything. Grafts take time to heal. So even when we do a reconstruction, frequently we're not getting a watertight seal immediately. It takes time for the grafts to heal. That's why we use packing to keep the grafts in place. So I avoid lumbar drains in most situations. So what we're going to do now is talk about different areas for reconstruction, because all the different areas that we can reconstruct have characteristics that we need to be aware of. So first, let's talk about cribriform. The cribriform area is going to be the most common area that we see a defect. We see a very subtle opacity in the olfactory fossa. This is very common with an idiopathic cribriform defect. Endoscopically, if we can get into that central compartment of the nose, we're going to see a little bleb, a little area that represents a meningocele. Frequently, we can't see these in the office because we can't get into this central area without manipulating the middle and superior turbinate. When we think about repair, we need to think about how are we going to address the middle turbinate? Are we going to resect it, or are we going to preserve it? And these defects can also cross the nasal septum, and I'll show an example of that. We also need to think about the olfactory fibers. So this is an example of a patient who came in complaining of some subtle intermittent clear drainage, which could not be collected. This was in 2009, where I got the CT scan and I read it as a normal scan. 5 years later, the patient comes in and same complaints, but more consistent drainage. Now look at this opacity in the olfactory fossa. This is an obvious meningocele, but in retrospect, this asymmetry, there was an obvious meningocele there 5 years earlier. So we need to pay attention to these subtleties. Endoscopically, it's not going to come out and jump out at you. We need to look for small areas. This is a meningocele high in the olfactory fossa at the cribriform plate. And we see here, this is a patient who's having a repair. You can see the olfactory fibers coming out along the upper part of the nasal septum. So we always need to talk with our patients, even if it's a unilateral repair, about hyposmia or anosmia. These olfactory fibers come out at 1 to 2 millimeter intervals, and they're more dense along the superior turbinate. So here's an example of a very small meningocele. This is actually a pretty common size, and this, I'm going to show you a repair. I do my repairs by preserving the middle turbinate. I open the ethmoids, do a complete ethmoidectomy, and I lateralize the middle turbinate. You see, I just bipolared the meningocele. Now I'm using a round knife with a long handle to elevate the mucosa circumferentially. We're elevating on the septum and on the middle turbinate that's intact to expose the cribriform plate. Now this mucosa is densely adherent, so frequently we cannot get all the way down to the bone. We don't need to. We just need to demucosalize this area and circumferentially expose the area of the defect. Here I'm using collagen matrix or dural replacement graft. This is a product from Medtronic called Dural Repair, and it's a very easy, malleable material. I use it in layers. The most important layer is the one up along the bone, but we can see that it lays in there nicely. The second layer just supports the first layer. And then I put gel foam packing in there. You can use Surgicel or anything to keep it in place. I then medialize the middle turbinate, put a little bit of packing in the ethmoids. Therefore, we have an intact middle turbinate that's supporting our reconstruction. And this is what it looks 4 weeks later. This is, you see vascularization from the periphery of this graft. Even though it's a free graft, after a couple of months, it'll be difficult to tell this from normal mucosa. Sometimes when we have patients with difficult to detect defects who have intermittent leaks, can't collect fluid, we need to really look at the CT scan. There's a couple of papers that we published within the last few years about particular defect called an excavating meningocele. And let me give you an example of a case. It's a 40-year-old obese woman with a 6-month history of 4 episodes of clear right-sided rhinorrhea. She developed a headache and then would have a leak, and then it would stop and the headache would subside. She could not collect fluid, so we could not test for beta-2 transferrin. And this is her CT scan. It looks perfectly normal. At least we thought so in the beginning. So what we then did is we did an MRI with intrathecal gadolinium that we could do delayed imaging. And if you look at the scan, first of all, let's look at the CT scan. Look up here at the cribriform plate and look at some lucencies here going across the upper septum and the cribriform plate. We really didn't think anything about that until we did the MRI. Now let's look at the intrathecal gadolinium here, right up here at the olfactory fossa. And we can see some gadolinium extending below the skull base into the upper septum. This is something that we termed excavating meningoceles, and we have a series of patients, approximately a dozen or more of these patients. This is what it looks like intraoperatively. We've dissected the mucosa off the plate. And now look at this little canal in the upper septum. That's an excavating meningocele. We can't just put a graft on this. We actually have to dissect out this canal, as you see here, take off the bone, follow it all the way to the cribriform plate. And now you see a meningocele. We're on the cribriform plate. We made this worse. We made it leak, but we need to in order to get all this meningocele off the septum. We're going to fast forward a little bit. Now we've got the defect. We're going to take this meningocele out, follow it all the way up to attachment. And now I'm putting a little piece of dural replacement graft actually in the canal. We need to plug the canal and then we can graft on top of it. If we just graft on top of it, we're going to fail. This patient actually recurred on the opposite side because if we saw from the CT scan, there was a little canal going to the other side of the septum. It's another example of a cribriform defect here on the right, leaking from the right side. Look at the defect and now look at the left side. The left side also has an opacity, a very low skull base. So if I talked to this about just fixing the right side, but with the possibility that we need to fix the left. Here's her, you look at the video, there's a defect on the right. You can see it moving in and out. But when we got intraoperatively, that's the right-sided defect, but look on the left side. There's actual meningocele on the other side. So this patient requires a central skull base reconstruction. They need the upper part of the septum resected. I'm going to fast forward through here. We actually need to do a single repair by removing the upper part of the nasal septum, extending across the midline, As you can see, the meningocele on the other side now after we've removed the septum. And we want to do a single repair here. I'm going to fast forward. There's our defect. Okay. We had a high, wasn't a high flow leak, but it was a significant leak. So I used some tissue glue here. And now I'm going to use, again, a dural replacement graft. We could have used a septal flap, although I did resect the upper part of the septum, but we could still have used a septal flap or mucosa. This is not a very large defect, so it will heal very well just with the dural replacement. Here's a layered graft. This is what it looks like 3 months later, okay? That tissue heals very well, so any kind of grafting is gonna work, and this is all extracranial grafting. Okay, the ethmoid roof. So, ethmoid roof defects are actually not that difficult to repair unless you need to resect the middle turbinate. So we need to assess if it extends across the middle turbinate. We need to know where the positions of the anterior and posterior ethmoid arteries are and the position of the frontal sinus. Do we need to graft into the frontal recess, in which case we need to clear the frontal recess? Here's an example that we showed before with a meningoencephalocele. And again, here we see a large meningoencephalocele. This is a little older video. I'm sorry, it's not high resolution or high resolution. So we'll fast forward. First thing we want to do is we wanted to open up the sinuses completely around the defect. Okay. The last thing we want to do is manipulate the meningoencephalocele. So we can find the ethmoids around this. Here after doing that, we're cauterizing and transecting the meningoencephalocele. In this case, I've got a defect right here. As you can see, a little round defect. I actually had two defects. There was one in front of it also. In this one, there was a fair amount of brain tissue, so I'm going to use a little septal bone graft to lay in this defect. We want to try to get it to fit in like a little piece of a jigsaw puzzle. Takes a little manipulation, but eventually it'll lock in there, as we see right there. And that'll support the anterior fossa structures. In this case, I'm using a mucosal graft. We've cleared the frontal sinus and we need to lay it across the ethmoid roof into the frontal sinus, the posterior wall. And here's what it looks like 6 weeks post-operatively. You can see an open frontal recess, a little scar tissue, that's fine, but the frontal sinus all the way up is completely clear. And now sphenoid defects. So sphenoid defects can be very easy or very challenging, and it depends on where the defect is. If we have a central posterior wall defect, that's very easy to access through the natural ostium with a wide sphenoidotomy. But if we have a lateral recess defect, especially with a very laterally aerated sinus, as you see on the lower right, we're not going to be able to access through the natural ostium. We need to do a transmaxillary, transpterygopalatine fossa approach. This puts the Vidian nerve and V2, especially the palatine branch, at risk. So this was described previously by Roy Casiano and Islam Harzala. And this is the window that we're going to approach this lateral defect. Again, a wide maxillary antrostomy, a wide sphenoidotomy, and then we need to go through the back wall of the maxillary sinus. This is with the maxillary sinus wall intact. This is after the posterior wall is resected. How we get there. This is removing the soft tissue in the pterygopalatine fossa. We either mobilize or we're going to resect the sphenopalatine artery. Let's fast forward this a little bit. But we're going to take this bone off the posterior wall of the maxillary sinus. Now, this is a sphenopalatine foramen right here probing. And now we can take all that bone off superficial and superior to it. I'm going to fast forward this for the sake of the video. Now we see the palatine nerve right here. as you see right here, moving vertically through that space. We can either transect that, but the patient will have palate numbness. We could try to mobilize it. As you see here, we're mobilizing it. But this approach allows us to get with a 0-degree scope into the lateral recess of the sphenoid sinus. As you can see right here, we're seeing the meningocele. And now is a full view of the meningocele. This is a video of that same approach. Actually, we're going to move forward. Let's go back here. Same approach, but we're going to preserve. We're going to try to preserve that nerve, that palatine nerve. So here's a medial approach. Now we have, this is the pterygopalatine fossa and the internal maxillary artery. We're going to work around it to approach the face of the lateral recess of the sphenoid sinus. Now we have a diamond burr. We're going to drill right through the face of that sphenoid sinus to create a keyhole opening laterally. And now we can get into that lateral recess of the sphenoid without transecting that palatine nerve. And you see this lateral wall meningocele. This preserves the palatine nerve, preserves palate sensation, and gives us direct access with a 0-degree scope. So this is how we're getting to most of our lateral recess defects now. And then we just perform an overlay graft and multiple layers in the lateral recess. Frontal, there's really nothing magical about frontal except for exposure. Do we need to do a draft 3 or a draft 2B in order to get access? Do we need to do above and below approach? So here's a large meningoencephalocele of the frontal sinus, the posterior wall. Frequently, when we see these large encephaloceles, they're not, they're mostly just filling the sinus, but they're not attached in the sinus. So we can extract them from the sinus fairly easily. We can see it pulling all that out so that we can defect. This is essentially approached the same way as an anterior ethmoid roof defect. We see the defect right here on the posterior wall. An inlay graft we will, and then the rest is just an overlay graft and doing whatever we need to do to keep the frontal sinus clear. Again, this is collagen matrix or dural replacement, and we can see we can do an overlay graft and we get a very good closure. So again, grafting material, we can use collagen matrix, we can use Mucosal, we can, for high flow leaks, we can use septal flaps. And of course, putting the graft in is important, but keeping it there is even more important. So that's why we need to be careful with our packing material. I use gel foam in small pieces that I place in the center of the graft and then work out and then put multiple layers to keep it in place. So just a couple more slides. This is a very complex defect, as you see here, multiple skull-based defects on CT. If we look at the MRI, large encephaloceles on the right, on the left, and you can actually see part of the ventricle coming into the sphenoid encephalocele. So this is going to require a more complex repair. We can't just use a little mucosal or a little dural replacement. This is all meningoencephalocele. So we'll fast forward. First, we need to resect this. We do that with a bipolar. This is a case I actually did with my neurosurgery colleague. Most of the other cases were done by myself. I don't use neurosurgery. I did in this case because of the ventricle coming through into the defect. So here's a partially resected encephalocele. We got a little vessel in there that will bipolar. Now we see the defects. We're looking at dura here with multiple pieces of bone fragments. We'll place an inlay of dural replacement graft. In this case, I am going to place a little bone graft because of how large the individual bone defects are. and how much brain was coming into the nasal cavity. And again, we need to take our time with these grafts. They will fit in. We don't need them to be watertight, but we need them to lock in there well enough that they're not going to move. Here's another bone graft, placing on top of the dural replacement. There we go. You can see that lock in there nicely. And now we're going to put a big nasal septal flap over everything. And we'll get that in place and then pack that in place with multiple layers of gel foam and other absorbable material. This is what it looks like a couple of weeks later. Pulsatile, healthy graft. We can see it on an MRI lighting up the vasculature. And we're going to skip this. It's a similar case. So endoscopic skull-base reconstruction, the success rate should be well over 90%, even for large defects. The keys are preparing the bed adequately. We need to adequately get exposure, remove mucosa and cratered bone preferentially, remove or reduce the encephalocele or meningocele, and then we need to close it in as many layers as we think is necessary. The soft tissue reconstruction needs to extend well beyond the bone defect edges. We can't be afraid to make the defect larger. If you're afraid to make it larger, you're going to fail. If you're afraid to take a non-leaking defect and make it into a leaking defect, you're frequently going to fail. And the failures come from inadequate access, not clearing the mucosa adequately, not freshening up the bone edges, not having a large enough graft, or not packing appropriately and allowing the graft to move. Thank you.
Compliments for your presentation and all those videos that were actually very interesting with high quality materials. Few questions I'm already collecting from audience. One of the questions is from Russia, and our colleagues is asking, are you using adrenaline when you do have a CSF leaks?
Yes, I do. I use 1 to 1,000 topical adrenaline. I don't have much problem putting it right over the defect. I have not had any problem. I don't use a lot of it. If I have a significant bleed, I'll use some topical thrombin, but I frequently use only adrenaline, topical adrenaline.
Perfect. The other questions is from a colleague from France, which is asking, are you facing any differences between leaks from the planum sphenoidale and the frontal beak?
So it's very uncommon to have a defect, a spontaneous defect on the planum sphenoidale. In the sphenoid, we usually see posterior wall or lateral recess. If we have a leak coming from the planum, since that is much thicker bone, it's usually a result of previous surgery. As far as the frontal beak is anterior, so we're not going to see a leak through the frontal beak. If we see a frontal leak, it's going to be in the posterior wall on the frontal recess.
Perfect.
Frequently, we need to get rid of the frontal beak in order to access the frontal sinus, though.
Sure. The other question is from a colleague from Egypt, which is asking, are you always using autologous material, or are you using allergen most of the time?
Yeah, no, so I'll use whatever I think will give me the best result. Sometimes I'll use I didn't show many septal flaps. I'll use a septal flap for skull-base reconstruction after tumor resection, or for some of these very large encephaloceles, like I showed at the end. Aside from that, I used to use mucosal grafts, free mucosal grafts regularly. Now I use mostly dural replacement or collagen matrix because there's no donor defect. It's very quick. We don't have to harvest a graft, and I can use it in layers. I can use it intracranial and extracranial. So I can use it on the nasal side or on the intracranial side. And that's why I said there's many different materials we can use, especially for low flow leaks, smaller defects. Really anything will work. Even fat plugs that are frequently used in Europe. We don't use them very often here in the United States. We do many more overlay grafts without fat plugs. We use fat if we have a big empty space after skull base resection. But most materials will work. It's more about the principles of exposure and repair than it is the actual materials.
Which is in fact one of the big issues that many of the residents or the young colleagues are facing up. When they see small defects, they try not to enlarge those defects because they are afraid to cause any iatrogenic defects also. But the key, as you said, is that you have to enlarge as much as possible with all around these to be prepared to have your grafts or whatever you want to reconstruct the whole defect. Otherwise, it will not be possible. The questions about what you already.
Can you speak closer to the microphone, please? There we go.
And then we reach into the another question which you already, I think, answered, which is the colleagues from Greece is asking what kind of flaps are you using after tumor resection, and you actually reply to that right now. I do have.
We can also, mostly we're using the septal flap, but we can use a nasal floor flap or a lateral nasal wall flap also, especially if the nasal septal flap has been compromised in some way.
Question,
or the septum has been resected.
Question from China. What are you using for after transsphenoidal transpituitary approaches?
Yeah, again, that again depends on multiple factors. Depends on how large the defect is. Many times we're just doing free grafts. For large defects, we're going to use nasal septal flaps. For extremely large defects, we may even use bilateral nasal septal flaps. And again, it depends on how large a tumor it is. If we're left with a lot of dead space inside the cella, then we're going to put something intracranially to fill that space. So we'll use fat grafts along with some dural replacement material underneath the septal flaps, because we don't want to lay the septal flaps intracranial. We'd rather lay them over the sphenoid sinus and use the fat graft or filling material for the intracranial defect to fill that void. Same thing if we have a big connection with the ventricle, we're definitely going to use vascularized pedicled flaps.
Question from United States. Miami is asking, are you packing nose after skull base reconstruction?
Right, so we definitely are putting packing underneath the flaps. When, for instance, if there's small defects, the cribiform defects, the ethmoid defects, then we're putting absorbable material, purely absorbable material. For these large skull base resections with septal flaps and large reconstructions, then we're using multiple layers of absorbable material and frequently some removable packs that will leave in for a minimum of several days. The last thing we want is for a septal flap to prolapse inferiorly away from the defect, which I've had one of those happen where after a meningioma resection and a septal flap reconstruction where the septal flap pulled away from the skull base, and now we have anterior fossa contents that are coming about halfway down the nose. So to avoid that, for large defects, we do want to put in some packing that's going to stay for probably up to a week, 5 to 7 days, to give that septal flap and that reconstruction some time to scar in.
Questions from Italy. What are the diagnostics preferred from you for diagnosis of CSF leaks?
So the majority of CSF leaks are going to be pretty obvious. So I try to have two criteria that the patient meets. One is that they have an active leak where they can collect fluid and we get a positive beta-2 transferrin. And number two is they have to have a skull base defect. I am not a big believer in exploring patients for a leak when there's not a high probability that they're actually leaking. So I like those two criteria to be met if possible. It's not always possible. Some people may have a defect but have intermittent leaks like the excavating meningoceles that I showed. And in that case, if they've got a good story like the intermittent headaches followed by clear drainage, along with a skull-based defect, then I think that would meet the criteria for repairing those defects. So that's the main thing, but CT criteria and preferably positive beta-2 transferrin.
Perfect. Houston, questions from Houston and the colleagues is asking, what are your post-operative treatment and management after reconstruction? Are you using high flow nasal douches or normal nasal douches?
So that's a great question, actually. I didn't have that in here because of the limited time, but so the post-operative care is going to be minimal. I have my patients on topical saline spray, not even rinses, because remember, we want these grafts to heal. We don't want to flush out the packing. We just want to keep it moist. So I have these patients just use nasal saline spray multiple times a day. I see them back 1 week later, and I remove a lot of the packing on the inferior part, but not expose the graft. I will then have them continue nasal saline spray, see them back 2 to 3 weeks later, and remove packing down to the graft. It's a balance between letting the graft heal and keeping the sinuses healthy. So I err on the side of letting the graft heal. I will not put these patients on high flow rinses for at least 4 to 6 weeks, or high volume rinses. And at that time, when I'm confident that the grafts are completely healed, then I will try to get the sinuses healthy, because frequently the mucosa will be edematous, there may be some granulation, and then I'll put them on high volume steroid rinses.
Other two questions. First one is from Amsterdam, who's asking, what are the tips and tricks for anesthesia in those patients, for before putting the patient on sleep and for awaking the patients?
Yeah, that's a good question also. We want these patients as quiet as possible. So as far as I'm concerned, paralysis is fine in these patients. We don't want them having positive pressure events. I don't even intubate all my patients with an endotracheal tube. I will use a laryngeal mask airway in a lot of these patients, even if they have a leak, as long as the anesthesia team can confidently keep them quiet without any positive pressure events. The most important things, obviously, as with any sinus surgery, is going to be keeping the bleeding under control, which means a low mean arterial blood pressure. And that will help with our visualization. But even more importantly is on awakening. Emerging from anesthesia, these patients really need to be woken up quietly. We can't have them bucking and having positive pressure events that could affect our grafting.
Perfect. And I think that there's a last question time. It's the last question is actually from Namibia. Namibia is very surprisingly a new place where people are connecting, and I'm very excited about that. And they are asking, what are the post-operative imaging and times for asking post-operative confirmation, I guess, something like this.
Yeah, so I don't routinely post-operatively image these patients at all. Now, I will for the tumor patients, but that post-operative imaging is for a baseline after resection so that we have something to follow when we're doing tumor surveillance. But as far as reconstruction of CSF leaks or meningoencephalocele, I do not routinely image these patients unless they're having some unexpected symptoms like headache or if they have any mental status changes, which are extremely rare. So I don't do any post-operative routine imaging. These are followed by nasal endoscopy in the office. And that gives us most of the information that we need. If we have some stenosis of the sinuses, then I may order a CT scan at some point to make sure there's not a mucosal or post-obstructive sinus disease.
I think that we reached to a final point, and you brilliantly replied to all these questions from all around the world, and I'm very excited. I'm very, very proud to have you here. I recently had this conversation with John when we were in Belgrade for an amazing event in Belgrade. So I asked him to join our ADHER-ENT First and 15 seminars and international ground rounds, and I'm really glad to have you here. Thank you again, John, for being with us. And soon, in the next few days, the whole registration will be able to be reached on our YouTube channel. I just want to address last thing. The next international ground rounds is planned for the 1st of November. And we do have Sarah Wise from USA, which she's going to talk about the international consensus statement on allergy and rhinology, and the topic is going to be allergic rhinitis. And at the same time, I would like to briefly invite you once again for the first Congress of Head and Neck Surgery in the Umbria region. People from all around Italy are coming, and we are going to discuss about the new strategies. And at the same time, we are going to submit a position paper to the Ministry of Health, and to include the nose inside of the head and neck management, because we should stress more and more about the nose and rhinology tumors on head and neck surgery. Thank you once again, John, for having you here and for your participation. And I will talk to you soon. Thank you again, and see you on the 1st of November.
Thank you.
Goodbye.
Goodbye.